All right, everyone, welcome to today's mini lesson on DOACs. And I am ChicagoDLSinc. I do one-on-one Naplex and MPJE tutoring in addition to group sessions. I know I've been promising them. There will be a schedule tomorrow posted to the group for several opportunities. And if you feel any of those are a good fit, feel free to reach out. Just a reminder there is a survey if you can complete that at the end of the session to give feedback. And shout out to Suspicious Bunch and Pharma Turtles for facilitating this as moderators of the forums. If you're new, please save all your questions. I'm happy to answer them at the end of the presentation, whether they have to do on the subject matter that we're going over or the Naplex in general. We will have practice questions at the end. The resources I use are RxPrep and Pass Naplex Now. Both of them are excellent resources. Whichever one you decide to go with, make sure you do it fully. Many people pass using RxPrep only, and many people pass using Pass Naplex Now. This is not a comprehensive review. There are many topics and details that may be missing. Hopefully not many, but there are several. So please make a note. So we'll get started. So DOACs are oral anticoagulants, and the major ones that we'll be covering are going to be Pradaxa, Xarelto, Eliquis, and Savaysa. The generics are going to be dabigatran, rivaroxaban, apixaban, and edoxaban. So some background here with some doses and then their mechanism of action. Some are going to be direct thrombin inhibitors, such as Pradaxa. This inhibits clotting factor 2A. And then Xarelto and Eliquis are factor 10A inhibitors. And then we have edoxaban. So we're going to start with Lovenox. Can anyone tell me the generic for Lovenox? Put it into the chat. Once again, the generic for Lovenox. So it is a 10A inhibitor, and we use it for DVT prophylaxis and hip knee replacement. The dosages are in bold. And if the creatinine clearance is below 30 ml per minute, we have an renally adjusted dose. For those of you that answered enoxaparin, that is correct. Great job. Pacific swells, I saw Ocarina. Autocorrect can sometimes be an amazing thing and then sometimes can be wild. DVT prophylaxis in abdominal surgery, 40 mg sub-Q once daily. These all are important. When taking the Naplex, there are going to be prophylaxis doses, and there are going to be treatment doses. Now, some will be for DVT or PE, and then some may be for AFib. And now looking at Lovenox towards the bottom, there's also an indication for MI, unstable angina or angina, thrombolytic adjunct, and PCI. So at the bottom, it says if you're greater than 75 years old, the dosage is going to be 0.75 mg per kg, sub-Q every 12 hours. Now, top right is a picture of Lovenox, and Lovenox will come in pre-filled syringes, 30 grams for 0.3 ml or 40 mg 0.4 ml. In addition, there will be graduated pre-filled syringes and then multi-dose vials. So storage must be at room temperature, and of course, dose adjustment if the creatinine clearance is below 30. Here are some instructions for the Lovenox sub-Q injection. Wash your hands, clean the area with alcohol. Patient should be lying down. do not expel the air bubble, and use abdominal fatty tissue, such as love handles. There are directions for how to inject, and then discarding in the sharps container. So, this falls into the low molecular weight heparin category, so we have precautions and monitoring. Enoxaparin, if the patient has a pork allergy, you need to be careful. And side effects can be hemorrhage, thrombocytopenia, bruising, fever, confusion, rash, and hyperkalemia. So, no routine monitoring is needed. That's one of the benefits of DOACs or DOACs. And you can order anti-10A levels 4 to 6 hours after giving the dose if you need to monitor the efficacy of treatment, but not routinely done. Uh, unless the patient is pregnant, renal dysfunction, obese or underweight, or has abnormal coagulation or bleeding problems. Check CBC at baseline and periodically check platelet, hemoglobin, and hematocrit. Now, for the treatment of overdose, you're going to discontinue the medication, and the drug of choice is going to be protamine. And protamine combines with heparin and heparin-like molecules, forming a stable complex, and that therefore there is no anticoagulation action. And for every milligram of enoxaparin that you get, you'll give 1 milligram of protamine. Now we have Pradaxa. Can anyone put into the chat the generic for Pradaxa? All right. And this is a direct thrombin inhibitor, factor 2A. The dosage forms come in 75, 110, and 150 mg capsules. The indication and dose is going to be non-valvular AFib. There are doses there based on creatinine clearance, and it looks like the cutoff is going to be 30 or um, 30 or above 30 mil per minute or 15 to 30 mil per minute. So we also have for the treatment of DVT and PE, reduction in the risk of recurrence of DVT and PE, and then prophylaxis after hip replacement. Note the hip replacement, we have the first day is going to be 110 mgs, then 220 mgs once daily for anywhere from 4 to 5 weeks. So continuing with Pradaxa or dabigatran, etexylate. These are some instructions not to chew, break, or open capsules. If the capsule is opened, 75% increase in absorption and can increase the risk of bleeding. So, good job if you answered dabigatran, by the way. So, if a dose is missed, it should be taken ASAP unless it is less than 6 hours before the next dose. Renally cleared here, however, the prodrug is a substrate. So, if the patient is taking a PGP inducer, such as rifampin, we want to avoid it, and you may need to decrease dose or avoid altogether. This is a pregnancy category C medication. If you recall, the benefit has to outweigh the risk in non-life-threatening situations. So converting Pradaxa from or to warfarin. When converting from warfarin to Pradaxa, we will discontinue warfarin and start Pradaxa when INR is less than 2. When converting the opposite way from Pradaxa to warfarin, and I know we're not covering warfarin today, but I just wanted to put it because it has to do with Pradaxa. Adjust the starting time based on creatinine clearance. If it's greater than 50, we'll start warfarin 3 days prior to discontinuing. If the creatinine clearance is 31 to 50, 2 days before, 15 to 30, start warfarin 1 day before. If creatinine clearance is less than 15, no recommendations can be made. Probably just throw up a prayer or pass the 8 ball. Because Pradaxa can contribute to an elevated INR, the INR will better reflect warfarin's effect after Pradaxa has been stopped for at least 2 days. So keep that in mind. Now, if the patient is on parenteral anticoagulants, we want to start Pradaxa 0 to 2 hours before the next dose, or if the anticoagulant is continuous infusion, we'll give Pradaxa at the time of discontinuing infusion. If patients are currently taking Pradaxa, uh, we'll wait 12 hours if creatinine clearance is around 30 mils, and 24 hours if creatinine clearance is less than 30 mil per minute. All right. Now, Pradaxa and surgery. Before surgery, we want to discontinue Pradaxa 1 to 2 days if, excuse me, before surgery, for creatinine clearance that's greater than 50 mils per minute. 3 to 5 days before surgery if creatinine clearance is less than 50 mils. Make sure that you stop Pradaxa 3 days before the procedure, 2 days prior, and the day of. Consider longer times for major surgeries, and if the surgery cannot be delayed, the risk of bleeding should be weighed against the benefit of urgent surgery. Now, you're asking, not yet, but you will. Uh, Labs. No labs are needed or required. However, there is a ECT or Ikarin clotting time test that can determine the anticoagulant activity of Pradaxa. So, it's better than APTT, PT-INR, or thrombin time. So, if ECT is not available, then APTT will provide a good second line or backup approximation. Now, let's go to the third point. You're asking, what if someone's on Pradaxa and they need emergency surgery? Well, there's an antidote. It's called Praxbind, idarucizumab, and it is available IV. It is a monoclonal antibody that binds specifically to dabigatran and neutralizes anticoagulant effect within minutes. Side effects of Pradaxa are going to be GI reflux and GI ulcers, and the GI irritation is going to come due to the tartaric acid core or tartaric. I always mention tomato with the pronunciation. It is a good thing no one is being tested on it. There can be bleeding and there can also be an allergic reaction. If the patient has hereditary fructose intolerance, there is 4 grams of sorbitol, and so you need to worry about the adverse reactions from there. There can also be hypokalemia, delirium, constipation, and pneumonia. Storage. I have seen a question. You may have seen a question. Pradaxa is stored in the original bottle or blister package to protect from moisture. For the bottles, you only open one at a time and use within 4 months. For blister packages, same thing. Do not open multiple and report any side effects to the FDA MedWatch. All right, now we're going to go to rivaroxaban. The brand name here is going to be Xarelto. There is a starter pack. The dosage forms are listed. And remember that if a patient is taking greater than 15 mg per day, make sure it's with food. If it's DVT prophylaxis because of knee or hip surgery, the times are 12 days and 35 days, 10 milligrams once daily. Stroke prophylaxis, if it's non-valvular AFib, they're listed. Same with DVT and PE treatment. Remember, all of DOACs or DOACs are high yield when it comes to the Naplex. So knowing their indications and their dosages based on based on the indication and whether it's prevention or treatment are very important. Xarelto is renally limited if creatinine clearance is below 30 ml per minute. Missed doses. Take ASAP. Here, the window is not similar to Lovenox, which was 6 hours. There needs to be a 12-hour gap between doses. Tablets may be crushed and mixed with applesauce. Monitoring. No monitoring, one of the benefits of DOACs. And before surgery, stop at least 1 day before. Now, drug interactions, this is a major CYP3A4 substrate, so if there's an inducer, avoid or give 20 mg QD. There's also an antidote, and it's Andexa or Andexanet alpha, also IV. Next is apixaban, and the dosage forms here are 2.5 and 5 mgs orally. The indications are going to be stroke prophylaxis in non-valvular AFib, DVT-PE, both treatment and prophylaxis, and the antidote is also Andexa. The window for a missed dose is going to be less than 6 hours, similar to Lovenox. And remember, rivaroxaban or Xarelto is 12 hours. Now, prior to moderate or high risk surgery, you want to discontinue 48 hours prior. And if it's a low risk surgery, 24 hours. Next, we have Savasa or edoxaban. Dosage forms are going to be 15, 30, and 60, and these are PO tablets. DVT-PE is an indication. Non-valvular AFib is another indication. And know that if creatinine clearance is greater than 95 mils per minute, do not use edoxaban. So this is like a reverse Uno for renally limited or renal function limited medications. If it's higher, edoxaban is not going to work. All right, next we have betrixaban, Bevixa or Bevi-Ixa. Actually, Bevi-Ixa doesn't make sense, so go with Bevixa. A tip, if you're not sure how to pronounce a medication, and I should probably be practicing what I'm preaching, if you go to YouTube and search for the commercial for the medication, boom, problem solved. So dosage forms are going to be 40 mgs and 80 mgs. Indications and dose are going to be there's going to be prophylaxis and V-Farm, you are most welcome. And with food at the same time each day. If a patient is taking a P-glycoprotein inhibitor, such as amiodarone, azithromycin, clarithromycin, ketoconazole, or verapamil, you want to decrease the dose and you want to avoid in severe renal impairment. In the chat, can you tell me a brand name for clarithromycin, please? Clarithromycin. All right. While you're answering that question, let's talk about weight greater than 120 kilograms. So, due to the lack of clinical data in this population, if the BMI is greater than 40, DOACs are you're suggested to avoid using it. Okay? If you do have to use it, measure peak and trough levels using anti-factor 10A assays or mass spectrometry. And if the drug level is below the expected range, change to a vitamin K antagonist. Good job on the Biaxin. Very good job. One thing I also want to mention is do not fall into the trap of anchor bias. For example, a patient comes and their BMI is very high and they're complaining of leg pain. Most people will default to lose weight, it'll take the stress off your lower limb. However, every patient, no matter their size, has health issues. So don't get caught up in that anchor bias. Very good, those of you that chose by accent. Now, we are to the practice questions. And for those of you that are new today, I'm going to read the problem, and at the end you can put your answers into the chat. Give everyone a chance to answer. If you are unsure, you can put a question mark next to it that it's a guess, or you don't have to, but still guess. And if any of the concepts are new to you, please make a note and a review later today after the session or tomorrow whenever you have time. Whenever you learn something new or are exposed to something new, the sooner you're able to go back and review that material, the sooner it will stick. So, practice question 1. An 85-year-old female who is 5'7", 54 kgs, presents to your ambulatory clinic for management of newly diagnosed AFib. Her physician referred this patient to you to assess which DOAC be most appropriate for the patient for stroke prevention. Past medical history includes hypertension, diabetes, and depression. Currently taking metformin 1 gram BID, lisinopril HCTZ 40/12.5, and sertraline 100 mg daily. Lab values are listed below from the BMP. Sodium is going to be 134, potassium is going to be 4.2, chloride is 103, calcium is 9.8, carbon dioxide is 24, BUN is going to be 12, serum creatinine is going to be 1.1, and glucose is going to be 128. Which of the following would be the most appropriate recommendation to the physician? A. Apixaban 5 milligrams BID. Choice B. Apixaban 2.5 mg BID. Choice C. Rivaroxaban 20 mg daily. And choice D. Anticoagulation is not indicated in this patient. Now, as you're typing your answers, just a reminder from our previous sessions, not only does the medication name have to be correct, but so does the dosing. So please double check. And make sure. All right, so getting some answers, and I have B. Actually, most chose B, and that is the correct answer. And let's talk about why. B is the correct answer because we're going to have, let's actually address A. Choice A is the normal dose, 5 mg BID. So Archer, good job on that one. However, if the patient has any of the two following criteria, greater than 80 years of age, body weight below 60 kgs, or serum creatinine greater than 1.5 mg per deciliter, then there will be a dose reduction. Because this patient is greater than 80 years of age and the body weight is below 60 kilograms, we will do a dose adjustment. So choice B is correct. And that's why A is incorrect. Now, choice C, rivaroxaban, as you know, is a factor 10A inhibitor. And this patient has a creatinine clearance of 31.9 mil per minute if we did the Cockcroft-Gault equation. And because that is their creatinine clearance, we would want to do 15 mg daily instead of 20. Okay, so rivaroxaban could be a correct choice. However, the dosage is incorrect. And then D, because we're choosing one of the three options, D is incorrect. Great job. This covers the areas 1, 2, and 3 of the Naplex, identifying drug characteristics, developing treatment plans, and oh, I had it and I forgot it. But it is areas 1, 2, and 3. Does anyone have any questions or concerns so far? Good job, everyone. All right, let's go to the next practice question. Oh, I had an arrow with the correct answer. Practice question 2. CG is a 57-year-old male admitted to the ED and diagnosed with a new PE, and the patient is hemodynamically stable. Past medical history is significant for diabetes mellitus, however you pronounce it, hypertension, hyperlipidemia, and osteoarthritis. Labs upon admission are within normal limits. Weighs 80 kilograms, 6 feet tall, and has no known drug allergies. Initially, enoxaparin 80 mg SQ BID for therapy. On day 3 of hospitalization, the team wishes to transition him to a DOAC instead of warfarin. Which of the following DOAC regimens is appropriate to transition CG from his enoxaparin, assuming he can afford therapy? Choice A, rivaroxaban. Choice B, apixaban. Choice C, dabigatran. Choice D, edoxaban. Edoxaban is 30 mg orally once daily. Dabigatran 150 mg orally BID. Apixaban 10 mg BID for 7 days, followed by 5, and rivaroxaban 20 mg QD with evening meal. All right, getting a good consensus here on B. And just know that on the Naplex, there is no pattern. So this practice question 3B should not be correct also. Apixaban, Eliquis, is given at 10 mg BID for 7 days, followed by 5 mg BID in patients with venous thromboembolism. So yes, B is the correct answer choice. Now C is the correct dosage. However, you need 5 days of parenteral anticoagulation before switching. So, because this is also called bridging, and so this patient has only received 3 days of therapy. So, C is incorrect. Choice D is also similar to choice C. Edoxaban also requires at least 5 days of parenteral therapy. And then the dose should be 60 mgs because the 30 mg dose is for renal clearance 15 to 50 mil per minute. Yeah. So D, while correct, still needs 5 days, and this is the renally adjusted dose. And then A is correct if the condition was AFib. For VTE, it's going to be 50 mgs BID for 3 weeks and then 20 mgs daily. So, this also is an area 1, 2, and 3 question. And you may ask, how can it be 3 areas? This is what's called a cross competency practice question. So it tests you in multiple areas. And depending on the Naplex, it may fall into one of those 3 categories. Okay, so this is kind of like a multi-level review. Great. Any questions or concerns about number 2? All right. If you remember one later, you know how to find me. Now let's talk about practice question 3. A 70-year-old female reports to her primary care with reports of mild lightheadedness, but is hemodynamically stable and otherwise feels well. Her past medical history is significant for HFrEF, which is heart failure with reduced ejection fraction, type 2 diabetes, reflux, and allergic rhinitis. She weighs 50 kilograms and has a serum creatinine of 1.0 mg per deciliter. Upon workup, she is diagnosed with AFib. Excuse me. Which of the following regimens would be appropriate for managing her AFib long term? Select all that apply. Well, I guess you get a freebie with choice C. Just know that with select all that apply questions, it can be one of them, it can be all of them. So both RxPrep and Past Naplex now do a great job of not setting any patterns because there are no patterns. All right, getting some answers coming in. Okay, so the correct answers here are going to be B and C. All right, so good job on that. And let's talk about why. So for this patient, you're going to use the CHAD-VASc score, and that's going to be CHAD-VASc is going to be congestive heart failure, hypertension, age, diabetes, stroke, vascular disease, age, and sex category. So whether they're male or female. So I'm going to put it into the chat. And all of these earn 1 point, except for previous stroke or age 70 greater than 75, which is going to be worth 2 points. So A is incorrect because this is the dosing for newly diagnosed DVT or PE, not AFib. Choice D is incorrect because this is the prophylaxis dose for VTE, not the treatment dose for AFib. All right. Aspirin therapy is not indicated because this is not an anticoagulant. So B is correct due to the renal dosing, as well as C being the correct renally dosed edoximab. Remember, no DOAC should be stopped abruptly due to increased risk of stroke. So just keep that in mind. Good job if you chose B and C. Does anyone have any questions or concerns about number 3? Good job. All right, practice question 4. What is a potential disadvantage of DOACs compared to warfarin? Select all that apply. Choice A, direct cost. Choice B, diet changes can impact blood concentrations. Choice C, more drug interactions. Choice D, twice daily dosing for some. Choice E, inability to assess for adherence through blood levels. Remember what are potential disadvantages. All right, getting some answers. Good. So the correct answers are going to be A, D, and E. Got the arrows right. So direct cost, they're generally more expensive than warfarin. Some require twice daily dosing. And choice E, there's an inability to assess for adherence through blood levels as easily as just doing the INR test. So if you chose A, D, and E, great job. Very, very good job. All right, so that concludes today's mini lesson and practice session. Does anyone have any questions or concerns about the topic today, or the questions that we've done, or the Naplex or MPJE in general? If you have taken the Naplex before and have a score report, you're welcome to send me a direct message and I'd be happy to provide you with feedback. Or if you've taken an assessment and would like some feedback, I'd be happy to do that as well. Remember, you are all on this journey. Keep up the good work, try your best, and you will get the result that you are looking for.